of the heart and basic views. Is the screen visible?
Yes.
Okay. So now before we start the machine, now we have to have quick start. Basically put the power on, keep the machine in the right of the patient. So when a patient is lying, the machine, the probe and the machine should be on the right side of the patient. Pick up the probe on your right hand if you're right-handed. Enter the particulars of the patient. Keep patient in supine attached ECG leads. So ideally, when you're doing echo, ECG should be done so that you're able to exactly know the cardiac events. Select the appropriate probe as we studied in the last lecture. Select pediatric cardiac program, and because this is very important, because some presets are there which will automatically come, and you don't have to struggle for the various range of the Doppler and other things. Also the uniformity of the shadow and depth and all the other things. So identify keys. So always remember that when you're dealing with a new machine, make sure that before you start actually doing the echo, spend good 5 or 10 minutes and identify all the buttons that you require. Every machine has got some uniqueness, and these buttons are either they are touch control or they are separately physical buttons are there. And many times, where is the depth, where is the storage, where is the gain. So all these are very important buttons, and that we need to find out before you actually start doing the echo. Because once you start doing echo and then there you are struggling, then it becomes a problem. Now always, I don't need to talk about hand washing. Clear the area on the chest, adjust the temperature probe and cardiac leads, pre-warm the jelly if feasible. This is a very common problem that jelly is very cold. As soon as you apply on the chest, the baby will just wake up and start fidgeting. Clean the probe of the echo as per the manufacturer's guideline. One can use chlorhexidine or 70% alcohol. Position the infant supine with the head in neutral position. Do not continue the study if the baby is agitated, baby is becoming hypoxic or hypotensive, or baby is getting hypothermic, or baby is having bradycardia, or actually baby is requiring CPR. So in this scenario, just don't do the echo because that will cause more harm. Soother will be calming the baby. So one can use soother, one can use 24% sucrose and keep the infant comfortable. Now, a very common problem that I see is that when I'm doing a echo, nurses feel now sir is coming for the echo. So the poor baby is comfortably sleeping, and sir aa rahe echo ke liye, so they'll just open the baby, remove the plastic wrap, and just make baby, just wake up the baby, and baby will become uncomfortable and start crying, and your whole purpose of doing echo will be lost. So this is a common problem. So I just advise nurses that you don't do anything. I will only wake up the baby. I will only open the baby. Now it's very important how to hold the probe. Now this is a very common problem that I see. A lot of people, a lot of when we conduct the workshops, a lot of people, they will hold the probe like this, hold very proximally. But then you have to remember that you have to hold the probe with your 3 fingers, and your 1 finger should be on the baby chest so that you are able to gauge how much pressure you are applying on the baby chest. I have seen new students doing echo and they are pressing the probe so hard on the baby chest that the baby goes into the bradycardia. So it's very important that how much pressure you apply on the baby chest. Now if your 1 finger is touching on the baby chest, with baby's movements, the finger will remain, the probe also will not lose the contact and will get proper, the probe also will move with the baby's movement and you will get proper images. So this is something practical which I'll demonstrate. Now there is something called as probe orientation. Every probe has got some marker on one side, and that marker generally corresponds with the marker on the screen. So here, as you can see, this particular marker on the probe on the right side will be seen on the right side of the screen as here it is shown. Now when we talk about orientation of the probe, we talk about a clock on the baby chest. Imagine a dial in front of the infant's chest for proper orientation. So when we say that orientation marker, so this is the orientation marker. Orientation marker is at 3 o'clock. It means that you're putting a probe on the baby chest with the orientation marker pointing towards 3 o'clock and vice versa. So basically this is very important for our orientation and orientation of the image. Now there are 2 orthogonal planes when you are talking about echo in the heart, echo of the heart. One is a long axis and short axis. So at different acoustic windows, we are going to say that it's a long axis parasternal or a short axis parasternal. Long axis apical, short axis apical, like that. So basically, this what we have to remember. So the long axis is goes from the root of aorta to the apex. And the short axis is an axis which is perpendicular to the long axis going from the base of the heart. So at the place where all the great vessels are attached to the heart. So that is the place which is perpendicular. That is the kind of axis which is perpendicular to the long axis. So when we do imaging, always remember that when we talk about long axis, your orientation marker is somewhere around 11 o'clock. And when we talk about short axis, your orientation marker is somewhere around 2 or 3 o'clock. Now coming to the next important aspect is image optimization. Now this is very important. This is better practice than taught, because the image optimization will happen only with practice. You have to always spend some time with your machine and probe and with babies. So you have to use correct probe, correct frequency, proper orientation of the probe, proper depth optimization, aligning the probe with the axis of the body of the baby, rotating, tilting the probe, proper gain, proper focus, and proper resolution. All these things are better taught bedside, shown on the baby rather than showing here on the PPT. But I'll still make an attempt what we mean by each one of them. So we learned about correct probe and correct frequency. When we talk about neonatal echo, we talk about small footprint sectoral probe, which has got a frequency around 7 to 8 megahertz. Orientation we learn, it is it's a imagine a dial on the baby chest, and for different views we talk about 2 o'clock, 3 o'clock, and the orientation marker should be pointing towards that. Now optimizing depth, alignment, rotation, tilt we'll talk. So how do you optimize the depth? So basically the depth should be such that the area of interest should occupy 70% of the screen. So if you're talking about long axis parasternal view, the heart should occupy 70% of the image. Now here on the left side, there is optimal depth. You are able to see the entire heart, and then there is some space below that also. Now the middle image, as you can see, you are not able to see the posterior wall of the heart. So this is an insufficient depth. And here on the right side, the heart is occupying 50% of the image. So basically this is a excess of depth. So basically you have to adjust the depth to get a proper 70% occupation of the screen. Now I call this as art of image optimization. Basically alignment, rotating and tilting the probe to get a image, proper image. So when we say align the probe, means that place the transducer on the baby's chest at a designated window and align it with the axis. So when you're taking a long axis image, align it with long axis. If you're taking a short axis, align it to short axis. Many times this movement is on the surface of the chest. So you have to actually physically move the probe on the chest surface. So many times this is not angulation. So aligning means you may have to move the probe on the baby chest like this or like this. Then rotating. So once you find the exact aligned axis, you may have to rotate the probe in order to open the heart, in order to get the optimal image. And sometimes you may have to tilt the probe. Okay, so now these three methods, aligning, rotating and tilting the probe, these are very important movements of the probe, and that one has to do very rigorously or very carefully in order to get the crisp and good image. Now, as you can see here, there is a good depth of the image, but here it is very good that the middle image is proper horizontal alignment. 70% of the screen is occupied by area of interest, and so this is a proper depth and proper image. But here, if you see, the interventricular septum is kind of oblique. Sorry, it is pro. So here if you see the interventricular probe is not here, the interventricular probe is horizontal. The heart is horizontally oriented. But here if you see it is little oblique. So here what you will do, you will have to move the probe little upward on the baby chest and then look little down and you will get this type of image. Or suppose you are getting this image where there is ventricular cavity is cut short. Now ideally ventricular cavity should be like this, but here the ventricular cavity is cut short. Now here what you require is a anti-clockwise rotation of the probe. So rotating movement will help. All right. So basically this is easier shown than easier done on the baby than shown here. But when we do that, we have to make sure that we are actually doing these three movements: aligning, rotating, tilting, in order to get a proper crisp image. Now let's come to the echocardiographic windows. As I said, there are specific windows on the head for head ultrasound, and there are specific windows on the chest for the cardiac ultrasound or cardiac echo. So we know that ribs are a hindrance for the ultrasound beam, and air-filled lungs are hindrance to the ultrasound beam. So basically, we find out places where you are able to get good images. So these are the four places where you get images, and these are standard imaging of the heart. So there is apical view, there is parasternal view, there is suprasternal view, and then there is a subcostal view. So this is the subcostal area, apical, parasternal. Parasternal is divided into low parasternal and high parasternal, and this is a suprasternal view. Now, this is a very important slide, but sorry for the busy slide, but it's very important to understand. I've tried to put everything in one slide so that we know in which view what we are looking at. So basically, when we talk about apical view, so we'll talk in detail about these views. So there is something in apical view, there is apical 4-chamber and 5-chamber views. In parasternal views, there is a low parasternal and high parasternal views. There is a suprasternal view, and then there is a subcostal view, and then I will talk about each view there. So this apical 4-chamber view, you put the pulse, you put the ultrasound probe at the apex of the heart, which is generally below the nipple line. Tilt the probe in order to get a image of the heart. The orientation marker is pointing towards 2 or 3 o'clock. Around this is the orientation marker. So this is the marker and it is facing around 2 to 3 o'clock. And then the image you should get is something like this. This is the 2D image of the heart. Okay. So now a lot of people believe that it will be a better to do imaging in a physiologic manner. So a lot of people, they will do invert the image so that as if you're looking from down upwards towards the heart. And a lot of people believe that this is a more physiologic imaging. Cardiologists will do imaging of the heart in this manner. We as a neonatologist generally will not reverse the image, but a lot of cardiologists you will find that they're doing imaging like this, as if the heart is sitting on your probe and then you're looking inside the ventricular cavity. So in the apical 4-chamber view, you look for structure of the heart, chamber size, ventricular contractility, pulmonary hypertension. You will see if the interventricular septum is not moving properly, and if you will be able to see fluid collection around the heart. And you can do the Doppler across both the walls. You can also get idea about diastolic function of the heart, and you can also see movement of the blood across interventricular septum or interatrial septum. Now, as far as anatomy of the heart is concerned, there are some golden rules which you must know, because otherwise sometimes the interpretation becomes difficult. How to identify a particular chamber? There are some golden rules. So the first golden rule is says that these are the kind of thumb rules. Basically, tricuspid valve is the one which is placed apically. So if you look carefully at the point where tricuspid valve is attached and at the point mitral valve is attached, you will find that both of them are not in the same line. One valve is slightly towards apex. So this is apex of the heart, and one valve is slightly towards apex, and the other valve is slightly distal, like away from the apex of the heart. So the one which is more apical is tricuspid valve. So suppose you are getting a wall which is more towards apex on this left side, then that wall you're going to call as a tricuspid wall. But again, you have to remember that walls are faithful to their ventricular chamber. So this is a tricuspid wall, and because this is tricuspid wall, this is the right ventricle. Now this is a golden rule. This cannot change in any of the cardiac anomaly or congenital heart defect. Cardiologists identify chambers, identify wall, and identify the underlying anatomic problem based on these some golden rules. So the first rule, as I said, is that the wall which is more apically placed is the tricuspid wall, and the tricuspid wall is faithful to the chamber which is attached. So it is attached to the right side of the, so it is attached to the wall, and that is right ventricle. Now, as you can see, here you will be able to see sometime primum ASD, which is just above the AB cushion, or sometimes you will be able to see defect in the interventricular septum, and you will see the flow from left to right. Now, can anybody identify a problem here? This is just 2D imaging of the heart. Apical view, slightly subcostal it has become, because in apical view, the interventricular septum is looking like this. Actually, in apical view, it should be dead vertical. So the image is actually a subcostal view. Can anybody tell what is the problem just looking at the heart? So this is the LA and this is the RA. So one second. So this is so these two golden rules we heard. Now third golden rule here I would like to tell is that the atrial chamber, which is the farthermost away from the probe, is left atrium. Okay, so the left atrium is deep seated. So this is the left atrium. You can also go by valve. So this is the valve. This is the right ventricle. This is the tricuspid valve. So what do you see strikingly different here? Is there any difference in the size of the atrium and ventricles? So if you look at this, the left atrium is smaller as compared to the right atrium, and the left ventricle is smaller as compared to the right ventricle. So you further put the color Doppler and you find that there is a tricuspid jet, and you further put the continuous wave Doppler there, and you see that there is a tricuspid regurgitation velocity which is very high and giving the pressure gradient between the RV and RA to the tune of 56 millimeters mercury, which is a significantly high. So basically this child has got a persistent pulmonary hypertension of the newborn. But just looking at 2D imaging also you can make out that the right sided cardiac chambers are dilated, and probably this child has got a PPHN. Now look at this heart. So basically in this heart, the ventricles ventricles are slightly dilated and the contractility is poor. So I think video is not there. Again, this is a heart where there is a contractility is better. And so again, the contractility, I think the video is not playing. But yeah, again, basically one can find out that the cardiac contractility is better. On 2D imaging also you can see whether the heart is contracting or not contracting. Then as you put the probe on the apical 4-chamber view, it slightly tilt downwards and rotate it clockwise. So tilt the probe downwards and rotate slightly, and you will get the opening up of aortic root. So this is the aortic root that you open up. So then these are the apical 5-chamber view. So LA, LV, RA, RV, and then there is a aortic root. So the aortic root is a 5th chamber that you are able to open up with the apical 5-chamber view. Here you put a color Doppler and you will be able to see the velocity of the jet going into the aorta. As you can see, this is the velocity of the jet going out from the LV. So this is used for structural assessment, fluid collection, flow across the valves, and flow through the aorta. So here you can calculate the VTI. I'll show it later on to identify cardiac structure. So this is LA, LV, LVOT, you put a Doppler here and you get this flow like this. Okay. Now the duration of this is left ventricular ejection time, and you are also able to get VTI. So I'll talk about VTI later, but basically these are the things which you require for calculating cardiac output. Then coming to the subcostal view. So basically first one is apical 4-chamber, apical 5-chamber view. Then is a subcostal view. Now the probe is placed just below the xiphoid with the pointing towards 3 o'clock. And then you will be able to see a one pulsatile structure on the left side and one non-pulsatile structure on the right side within the parenchyma of the liver. And that one is a right sided structure, non-pulsatile, going through the liver is IVC, and the pulsatile one is a abdominal aorta. And here you will be able to identify the situs, whether it is solitus or inversus. Also, you can get tilt the probe to get the subcostal view and sweep it upwards. So the probe which is there in the subcostal view here, probe your upwards, go towards the heart and look at the heart. Here you will be able to see the 2D structure of the heart. Interatrial septum, which is close to the probe there. You will be able to see the pericardial effusion. You will be able to see the Doppler here. You put the color Doppler here, and you'll be able to see the flow across the PO4 ASD, and you'll be also able to see the flow which is coming into the SVC. So basically, don't get confused too much. Subcostal view is used to assess the atrial chambers. As it is shown here, this is the LARA interatrial shunt, which is a PFO. In the middle of the heart, if you are able to see this flow, you will be generally able to see a flap here, and the flap opens and closes, and that is basically a PFO flow. So the interatrial shunt you will be able to see, and when you put a Doppler, pulse wave Doppler, you get the velocity flow like this, 70 to 80% left to right, and 10 to 15% right to left shunt, which is a normal. SVC flow also you are able to see in this, but again, as I said, SVC flow we are not using much. Then coming to the subcostal long axis view. So basically here you are able to see so here the probe you have subcostal area, you're going to put it a long axis so that the orientation marker is 12 o'clock. And here you will be able to see the longitudinal anatomy of the IVC, and it will help for the distensibility of the IVC. So this is the probe. When you put it like this, you'll be able to see the IVC, the hepatic vein which is opening into the IVC pulsatility index, fluid status of the patient, you'll be able to know. So here, as you can see, this is the abdominal aorta. This is a celiac artery. Then there is a superior mesenteric artery. Celiac artery, superior mesenteric artery. And this you will be able to see in a long axis view. Please remember, when you're doing a subcostal long axis, on little left side, you'll be able to see the aorta with the celiac and SMA. And when you put little on the right side, when you tilt it little right towards the liver, you'll be able to see the IVC which is running through the hepatic parenchyma. Now identify the problem. Can anybody identify the problem here? Anybody?
Effusion.
Yes. So this is a pericardial effusion. As you can see, the heart is floating in the water, and then there is some fluid which is a dark peach in color. It means that this is just a fluid consistency, and there is something in the pericardial space, and there is a pericardial effusion. So sometimes you have a problem as clear, as obvious as this. So don't try and go finding clues. Clues may be there. It may be obvious just in front of you. Then coming to the third important area on the heart, which is a parasternal long axis view. So parasternal long axis view is the area which is just on the left of the manubrium, sternum, and second, third, fourth intercostal space. And here the orientation marker is pointing towards 11 o'clock, and you will be able to assess the heart. So what you see is that you should be able to see the heart lying horizontally like this. This is the LA, LV, LVOT, aortic wall, aorta. And this is the right ventricular tract which is enveloping around the heart. Now this is called as Plaque's view. That is a parasternal long axis view. This is called as Plaque's view, and you will be able to see so many things. This particular structure is a ductus. This particular structure is a descending aorta that you are able to see. The aorta is seen in picture in a cut in an oblique format. So this is seen behind the LA. So always remember, behind the LA, the vessel that you see is a descending aorta. Now, when you see this image, you have to sweep. But as you go medially, you will be able to see the tricuspid wall, and here you will be able to see the tricuspid regurgitation if the patient is having. So if you sweep medially, you will be able to see the tricuspid wall and regurgitation. Then come to the neutral midline position, where you will be able to see the cardiac contractility. This is LA, LV, LVOT, and here you will be able to see the contractility, opening, closing of the mitral valve. And then go little laterally, and then you will be able to see the crossing of great vessels. So the vessel which is coming from top going down is a pulmonary artery, and the vessel which goes from below upward is a aorta. So then there is a crossing over of these two vessels in this view, and here you will be able to rule out TGA. In TGA, you will see double barrel sign. Both the vessels will be seen next to each other like this. But normally the vessels they cross like this. So this we will see in reality, but how it is seen, you will be able to see here like this. So what to see in Plaque's view? Look at the tricuspid wall, rule out TGA, look at the structures of the LA, LV, LVOT, look at the mitral wall, do the Doppler assessment. If there is any VSD, you will be able to see blood jet coming from across the VSD, and you can do M mode here to identify cardiac contractility or fractional shortening. So again, golden rule is that the vessel which divides after originating from the heart is pulmonary artery. So this is very important because many times you're not able to identify which is the aorta, which is the pulmonary artery. So artery which divides immediately after jetting off from the heart is a pulmonary artery. So again, this will help you to identify presence of TGA. Many times you'll be able to see VSD in this view, parasternal long axis view. Then we go for the parasternal short axis view. So here is the long axis like this. The orientation marker is facing 11 o'clock. Okay, we just diagonally, we 90-degree we rotate. Now the orientation marker is facing towards 2 o'clock. And here you will be able to see the short axis images. So this is the short axis as pointing towards the left shoulder. And there's a sweeping movement till apex. So when we do like this, you do the sweeping movement till apex so that you're able to cut the heart towards the apex. So something like this, cup and saucer appearance, you'll be able to see. This is the cup in the center, and then this is the saucer. So the cup is formed by aortic wall and the Mercedes-Benz sign. That is the three leaflets of the aortic wall. And then there is a LA, RA, RB, and RVOT is kind of envelopes around the aortic root. And this is the cup and saucer appearance you'll be seeing in a parasternal long axis view, in a parasternal short axis view in a lower part. So lower parasternal short axis view, you'll be able to see cup and saucer appearance. Here also you'll have an idea about left atrial size. So here, as you can see, as you go down, initially you'll be able to see the leaflets of the aortic wall. Then you'll be able to see the papillary muscles and the you'll be able to see the LV and papillary muscles, mitral wall leaflets. Here they're opening, closing, and just below the mitral wall leaflets, you'll be able to see papillary muscles. And this middle area, you can use it for assessment of cardiac contractility. So we'll talk about it later. Then coming to the high parasternal view. So high parasternal is as you are doing it below, like third, fourth intercostal space, left side, you move up to first and second intercostal space. Long axis, the orientation marker is towards 11 o'clock or 12 o'clock. Okay. And here you will be able to see the ductal view. So here you may have to tilt the probe in order to see the pulmonary artery. As the pulmonary artery is going down, it divides into the left and right pulmonary artery. But there is something sometimes seen as an apical or a cephalic extension of a main pulmonary artery, and that extension goes directly into the descending aorta like this. So this is the descending aorta, and the blood is coming from descending aorta into the main pulmonary artery. or left pulmonary artery, or main pulmonary artery. Here is the main pulmonary artery, and this you will be able to see in a ductal view. Then coming to the suprasternal view or aortic arch view. Many times we are able to see the arch properly through the high parasternal long axis view. But if you're not able to see, then put the probe in the suprasternal area and probe facing 12 o'clock and downwards. You'll be able to see the aortic arch. It will be seen like this. The first one is the brachiocephalic, then left common carotid, and then the left subclavian. Then when you're doing a suprasternal view, then you go for the crab view or go in a short axis. So in a short axis, the orientation marker is towards 3 o'clock. You put the probe in the suprasternal area, tilt it downwards, and go and try going into the left atrium. So this is the left atrium. Here there is 1, 2, 3, and 4. 4 blood vessels are draining blood into the left atrium. Now this is a crab view, and this crab view indicates that all the four pulmonary veins are draining into the LA, and this rules out TAPVC. Now same high parasternal view, basically short axis view, where the orientation marker is pointing towards 3 o'clock. Here you will be able to see the duct more properly. So here, as you can see, the high parasternal view, the main pulmonary artery, right pulmonary, left pulmonary is not properly seen, and then this is the cephalic continuation of left pulmonary of main pulmonary artery is a PDA. You put a color and you'll be able to see the PDA. So thank you very much. This is completes the anatomy of the heart and basic views. So if there are any questions, or we should move on. I think we take a 5-minute break. If there are any questions, then I think it becomes otherwise monotonous. So we can ask if there are any questions. Until now, if there are any questions. I hope everybody is there. I don't see anything in chat box.
I think people are a little lazy to write today now. But tell me, how do you sterilize the probe? You said you use an alcohol, but alcohol does not cause damage to the surface of the probe.
See, basically we go by the manufacturer instructions, and most of them they advise use chlorhexidine, damp cloth, chlorhexidine, and that we have to apply. And if it is obviously contaminated with proteinaceous material, then one can use 70% alcohol to clean it. And but again,